Hello, everyone. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about rheumatic heart disease. Now, rheumatic heart disease is a condition you probably would have heard and studied a bit about in your preclinical years. But today, I would hopefully like to focus a big part of this presentation on explaining the why of a lot of rheumatic heart disease specific things, whether that be presentations, how we manage them, how we diagnose them, what medications do we choose, and so on. So what is rheumatic heart disease and how does it fit in to some of the other heart conditions we study? It's important to know that rheumatic fever and rheumatic heart disease, so the rheumatic heart disease isn't actually an infection itself, but rather an autoimmune response that develops because of an infection. So remember, it's not the infection, but the autoimmune response that your body develops to the infection. The bug in particular that's most associated with rheumatic heart disease is group A beta hemolytic strep or strep pyogenes. The autoimmune response commonly affects the heart valves, the skin, the brain, and the joints, right? Remember, that's not what the bug affects, but what the autoimmune response is. Because this is a hypersensitivity reaction, obviously, you need to have a recent history of the infection itself, right? So you need to have an infection, your body then develops a response to it, but the response is a bit more than what it should be, which is why you get an autoimmune response. So where does the first infection actually happen? That's pretty straightforward. That's your strep throat. So with strep throat, you can often have viral and bacterial strep throat. If it's bacterial, one of the ones in particular we look out for is strep pyogenes or group A beta hemolytic strep. So what's going on here? Before we talk about risk factors, what's actually happening here? So you get your strep throat, you get infected, your plasma cells identify firstly the bacteria, they develop an antibody response to the antigen. However, the antigen that your plasma cells develop antibodies to tends to be quite similar to a lot of the tissue that's found quite extensively throughout your body. This includes cardiac myocyte. This includes central nervous system, subcutaneous and dermal tissue, glomerular tissue, and so forth. So now when you develop antibodies to this, and antibodies are going to go everywhere in your body, right? You're going to end up attacking all of these individual parts. That's not good. So what are some risk factors to developing rheumatic heart disease? Being of a male sex, being usually younger demographics tend to get rheumatic heart disease, so age between 5 to 15 years old. Socioeconomic status and being of an indigenous or Torres Strait Islander origin is a big risk factor for developing rheumatic heart disease. And it's one of the conditions that's quite endemic in certain areas as well. And obviously having a recent upper respiratory tract infection is going to be a big one. So signs and symptoms. So I'm sure over the course of the next year, you will learn these signs, but I think it's good to understand why these actually present the way they do. So you start off with migratory polyarthritis. What does that mean? So polyarthritis just means arthritis or inflammation of the joints. That's poly, meaning multiple joints are inflamed, and migratory means that it's at one point in time you can have a different set of joints and they can often end up with a different set over a few days. So it's migratory, meaning that the exact joints affected are never set and they can often change over time. So putting that into words, that's quite medical. So you have an autoimmune mediated inflammation, because we talked about how this is autoimmune, of 5 or more joints, which is when it's poly, and it affects different groups over the course of the illness. If the lower limbs are affected, the patient may have difficulty walking. Pancarditis, pan meaning all, carditis meaning inflammation of the heart. So you have inflammation of all 3 layers of the heart. So the pericardium, myocardium, and the endocardium. This can present with chest pain, shortness of breath, a new murmur, as well as a friction rub. The friction rub often develops because if when you have an inflamed pericardium rubbing against an inflamed myocardium, ideally they should gel well and should not have any turbulence or friction between them. But if they're inflamed, obviously that may not be the case and you may end up with an audible friction rub. The next one is neural tissue. Now this is quite interesting. The chorea, which is a sign that develops, refers to erratic unsynchronized movements of the entire body. It's actually a Latin word for a disorganized dance. And that's what it often looks like, where patients often lose control and have kind of unsynchronized, uncontrolled movements of the entire body. Now, this is quite a delayed hypersensitivity response and doesn't present usually 6 to 9 months after the illness. And therefore, it's one to warn. It's definitely an important one to warn patients about. Erythema marginatum. So we have these kind of circular erythema, and they can be often quite widespread, often present on the back, but can also develop on the chest and the limbs. And then you can also develop subcutaneous nodules because of that inflammatory infiltration into the subcutaneous space. Going back to our diagnostic criteria, because with some of these conditions, it can be really hard to diagnose them. So to diagnose this, you need, firstly, evidence of past infection. So that can either be a positive throat culture that comes up positive for group A beta hemolytic strep, or an anti-streptolysin or titer, which basically means that you have had a recent infection that was strep pyogenes, but you don't have one at the moment. So depending on when in the course of the illness you are, you may be positive for different things. So you need to know that often by the time you develop many of these symptoms, you will no longer have a positive throat culture, well, because the infection has passed in the upper respiratory tract and is now is the autoimmune phase. However, you would still expect the anti-streptolysin or titer to remain positive. In addition to that, you need either 2 major criteria or 1 major and 2 minor criteria, and those are listed below. So the major criteria, or the Jones criteria, so the J stands for joints, the migrating polyarthritis that we talked about. The O stands for pancarditis. The O, it's meant to kind of look like a heart. So you have involvement of the heart. I know it's a bit of a stretch, but stay with me. So you have the myocarditis, the endocarditis, or the pericarditis. The N in Jones stands for nerves, so chorea, which can often be a delayed response. Erythema marginatum and subcutaneous nodules. And then for minor criteria, you have CAFE-LP. So C stands for the elevations in CRP. I stands for arthropathy, that is non-migratory. Now, a big question that's often asked is, well, how is arthropathy different to the arthritis, right? Arthritis is the inflammation. So not only are they painful, they're also inflamed, versus arthropathy, which is just pain. And it often tends to be non-migrating. A fever above 38, ESR, now again, common question, CRP versus ESR. CRP is a more acute phase reactant and tends to fluctuate in the short term more, versus ESR reflects more so long-term inflammatory status. Because rheumatic heart disease can often be chronic and have chronic manifestations, you can have an elevated ESR. Leukocytes for the very same reason, and a prolonged PR interval. Now, why do you get a prolonged PR interval? Good question. Now, if you have an inflammation of the myocardium, right, within which you're going to have the entire cardiac electric conduction system, so from the SA node to the AV, bundle of His, Purkinje fibers, and so on, if you have that being inflamed, you may often have a prolonged period between atrial contraction and ventricular contraction, and that's going to be represented as a prolonged PR interval, right? In terms of other investigations you would like to order, so this page basically summarizes everything you need to know. However, some of it obviously fits into the diagnostic criteria. Other stuff is things you may look for. So part of the diagnostic criteria, we need a throat swab to look for group A beta hemolytic strep. Vital signs are always good to do. ECG, because often these patients will come in with chest pain. So it's always good to see if there are any arrhythmias or any ischemic changes or bundled branch blocks. In terms of bloods, an FBE is good because it can tell you about leukocytes. Additionally, UECs and LFTs are particularly useful because one of the common complications of that autoimmune reaction is going to be that reaction against your glomeruli. So you can often have a glomerulonephritis that develops. So you need to be mindful of that. Blood cultures, an anti-streptolysin or titer, which we talked about, and DNase B, which can also detect on a very similar level as the anti-streptolysin or titer, evidence of past infection, CRP-ESR that we talked about, and lastly, echo looking for vegetative growth and valvular involvement. Now, why do we do this? Well, it's a two-step process. Firstly, rheumatic heart disease and infective endocarditis often go hand in hand. This is because when you inflame or have microscopic damage to the endocardium, you are putting that patient at a higher risk of developing further vegetative growths. In addition to that, you can, just because of the rheumatic heart disease, often develop abscesses, regurgitations, but most commonly mitral stenosis is the most common valvular complication from rheumatic heart disease, right? How do you treat it? So you treat it with phenoxymethylpenicillin, which is pretty similar to your basic strep throat cover, right? And if allergic to penicillin, you use erythromycin. You can use NSAIDs to manage acute joint discomfort. Unfortunately, chorea itself doesn't have a particular treatment, and many of the other symptoms are managed conservatively. If you have confirmed rheumatic fever, you would, so this is for the acute phase. If you confirm rheumatic fever, you can then use benzathine benzyl penicillin, which is an intramuscular dose. Again, aspirin or simple analgesia for associated arthritis. However, once you do have rheumatic fever, you are at a much higher risk of developing all of those complications that we talked about, right? So you can often have rheumatic fever without the presence of rheumatic heart disease. And all that we've talked about, so diagnosing this, so this is the criteria for diagnosing rheumatic fever, okay? You can have rheumatic fever in the absence of rheumatic heart disease. And if that's the case, you need to really, really make sure that they don't have another episode, because if they do, they are at a high risk of developing rheumatic heart disease. And rheumatic heart disease is not fun. So you always want to give them some form of prophylaxis, and that's often going to be benzathine benzyl penicillin. Now, a question often arises as to why do you give benzathine benzyl penicillin? Why don't we give something else? Because obviously we've talked about penicillins. Why don't we give something like benzyl penicillin? Just your typical Ben-Pen. Why do we give benzathine benzyl penicillin? That's a really good point, and I think it's a really good question if people are thinking down those tracks. Very similar mode of action. However, you need to know that benzyl penicillin is given IV most commonly, and it has a very short action in terms of its half-life. Now, if you want to give someone prophylactic cover, and as you can see, we're giving this for long periods of time, years on end, you would not really want your patient to be receiving a dose every day or every other day, right? Versus benzathine benzyl penicillin is relatively longer acting because it's the inactive form. And therefore, you can go by giving this every 21 days. Now, how long do you give benzathine benzyl penicillin for depends on the degree of rheumatic heart disease. If you don't have any rheumatic heart disease during this episode or mild, it is 10 years after the last episode or until the patient is 21, whichever is longest. Which means if the patient is 10 at the time, you would give them antibiotics till they're 21. If the patient is 5, until they're 21. If the patient is 17, until they're 27, right? If you have moderate rheumatic heart disease, you give them antibiotics till they're 35. If they have severe rheumatic heart disease, which did not require cardiac valve replacement or surgery, it's 40 years. However, if it was severe that required surgery, you give them prophylactic antibiotics lifelong. I hope that all made sense. And that's the end of our lecture on rheumatic fever and rheumatic heart disease. As always, if you have any questions, feel free to get in touch with me on my email or through Facebook. And as always, please look after yourself and look after your loved ones. I'll see you guys next time.